Well, good morning, good afternoon, good evening, and welcome to If Data Could Talk. I'm your host, Andy Cotgreave, and today I'm joined by Sam Scarpino. He is Assistant Professor in the Network Science Institute at Northeastern University, and he's been doing a lot of work on COVID-19 in the last 12 months, and his work has been covered in the New York Times, the Washington Post, and the Economist. You may also have seen Tableau's own Path to Normalcy feature videos on our COVID Data Hub. Sam is the person who helped advise on that. So go check that video out. The links will be somewhere below this video. Today, we're going to be talking about vaccinations and some of the human aspects of the COVID-19 data. I'm really excited. So Sam, hi, welcome to the show.
Thanks for having me, Andy. I'm excited to be here too.
It's great to have you, really great. Now, but I'm going to ask a provocative question. You helped us do a feature about the path to normalcy. So we have vaccines. This is it, right? We are on a path to normalcy really soon, right? Or not?
That interestingly enough was one of the comments, the negative comments. You're not supposed to read those, but I do it anyways. The negative comments about the path to normalcy video is, it wasn't anything about what is normal. Right. And really the video and the conversation was supposed to be about what are we watching as we progress towards normalcy. It was about the data, about the indicators. But you're right. I think what the implication here is that the vaccine does not all of a sudden make things normal again for a whole variety of reasons.
And so you talk about several challenges in the video itself. Do you want to can you quickly summarize some of the most important ones, do you think, as we track what's now happening with the vaccine and rolling these out around the US and the world?
Well, certainly, one of the things that we struggled with from the very beginning of the vaccine rollout is just getting them delivered quickly enough, getting them injected into people's arms, getting people organized so that they knew when they're eligible. And that's in countries where the vaccine is being rolled out. It's grossly inequitable right now at the international scale. And there's a huge amount of inequality at the local scale as well, even in countries where people are being vaccinated. And so what that means is that it's going to take a long time for neighborhoods, cities, states, countries to reach a threshold of vaccination where transmission is going to be interrupted. And so as a result, we need to be layering in contact tracing, case investigation, testing, all of the things, mask wearing, all of the things that we have been trying to do for months and months and months now with COVID with the vaccines so that we can get to a new normal faster. And so the idea about this path to normalcy is it's not about the vaccines, it's about the vaccines and everything else we need to be doing to get there.
And do you think those data systems are in place, and how does the challenge of the human aspect come? Because as certainly here in the UK, we can see already people are getting vaccinated, so people want to relax their vigilance against the disease.
Well, it's a mixed set of results around the data as it pertains to COVID-19. So certainly, really never before in history have so many smart, talented individuals, so many technology companies, so many governments turned their attention to public health data. And so we have lots of visualizations, lots of bootstrapped efforts to capture, digitize, and share information. So in some ways, we're able to see things that we've never been able to see before. However, a lot of those systems are being generated and instantiated because our public health data systems have been so underfunded for decades and decades. And so we are able to go onto the New York Times and see vaccine delivery and coverage for COVID-19. We can't see that for anything else in the US on that scale. However, COVID is such a local disease that we really need to understand what's happening at the zip code level, what's happening at the postal code level, what's happening in different racial and ethnic groups that we know have disproportionately been affected by COVID as a result of racism, as a result of xenophobia. And that information we're still, is still obscured. Now, in terms of people's behavior, understanding behavior is a complex process, but we know that people are exhausted and it's going to take a lot of effort to encourage individuals to maintain physical distancing, maintain mask wearing, et cetera, once we start to get vaccination rates up high enough.
Yeah, that's fantastic. Are there any examples of how, where you say the revolution of the last 12 months, obviously it's been a terrible crisis and a terrible price we've all paid, but healthcare data or the data you've been working on has seen these benefits. Are there any specific examples you can give us of that kind of change?
Well, certainly, we've seen efforts coming out of academic institutions like Johns Hopkins. I'm a part of a collaborative with Boston Children's Hospital, Oxford, and a variety of other organizations to capture data and make it available via dashboards, via open access, APIs, or just download CSV files. These sorts of data tell us things like how fast are PCR tests coming back, which was it still is a big deal, but was a really big deal early on in the outbreak. And those pieces of data end up feeding dashboards like the RT.live tracker, where you can see the local growth rates, how we calculate them. It depends on what the delay is between when people are symptomatic and infectious and when the test results come back, which is typically when the data, pour in. We know obviously that Tableau and the larger ecosystem has built these, interoperable data sets that power dashboards and decision making. And so it's really kind of been across the gamut, from academics to journalists to private individuals who are just spinning up their own data systems that have happened over the past 12 months.
So and all those extra data systems come with some challenges, right? Because we're all human beings and we're prone to mistrust or over trusting things, misbelieving other things. So one of your areas of expertise is this psychology of human interactions with data. How have we been our own worst enemies or best friends in our responses to the public or to the government communications that have been sent our way and to the crisis itself?
Yeah, I'm going to remember that description of the psychology of human interaction with data. That's great. I've not heard it quite put that way before, but that really resonates with me. And that, I think, is certainly one of the generational challenges that we're dealing with. And it actually has a lot to do with why COVID became such a problem in so many countries, why we're dealing with, fake news in general. With COVID, if you have better data, that almost always means you're controlling the spread, because the data comes directly from people that are transmitting COVID to each other, that are protecting themselves from COVID. And so in some ways, there's such a tight coupling between the quality of the data and the quality of the public health response that just the quality of the data systems alone are a pretty good indicator of who's going to be able to respond and who hasn't.
Yeah.
So
go ahead. Well, I was going to say, there have been challenges over the year of are we using data to chase the wrong decisions? And I think in the UK we reopened restaurants, and I think you've had similar situation in the US with restaurants reopening and using that, but actually interpreting it the wrong way. Can you elaborate on that?
Yeah, so I know the US situation better, but I think it's similar in the UK that we aren't able to ascertain where most people get infected. And this is for two reasons. One, that once the number of infections grows large, it's just a daunting task for contact tracers to whittle down all the ways in which somebody might have gotten exposed. The second is probably 50% of people that get infected, they're infected by someone who doesn't yet have symptoms, which means you're not going to be able to remember back, sitting in the pub and somebody coughing at the table next to you. The person that infected you probably wasn't coughing. They probably didn't have a fever yet. And so just even being able to identify that is a big challenge. And so what does that mean? Well, it makes it harder for governments to appear as though they're making smart data-driven decisions, because really we're in a data poor situation when it comes to really knowing where cases are coming from. And
another aspect of that is, when we think of how people are trying to search for the data, was it the IMHE that had early success with the very localized format, localized predictions, which turned out to be an example where people grasped on something local but wasn't it wasn't accurate. Is that right?
Yeah, that's right. And well, what ended up happening there is, for years now, there has been a growing community of academics and public health officials that are interested in forecasting infectious disease outbreaks. And then IHME jumps in with their forecasts. They made a lot of the same mistakes that our field had made years earlier, and that we think we'd learned from and kind of moved on from. But it received a huge amount of attention and interest and buy-in. And that led to kind of a lot of sort of soul searching, which is, why? And I think the answer, as you were pointing out, is that they were the first to come up with hyper localized forecasts. And that's where the public health decisions are made. That's where people live. It's what they care about. It's why weather forecasts in some ways are so powerful, is that we care about what's happening around us, not what's happening in our state. And so we learned a lot very quickly about data visualization and about the importance of local information, just given the popularity of those forecasts.
Yeah, I find that really interesting. As we're recording, I'm beginning to sort of look back over the 12 months and think about, which were the charts that most influenced or tell the story of COVID over the last year. And at the start, everyone was scrambling for any kind of data. Right at the start, it was like, well, is my country doing worse than your country because we haven't got any better data? But then once you realized, well, all the countries, or certainly my country in the US, we're doing pretty badly. It's like, okay, what's happening here? So near me, and seeking that was sort of the second generation of scrambling. But as you said, the data and the models were not accurate enough at that stage. So I find that fascinating. And then, so you talk about political will and political decision making. You also work in AI and machine learning, and how has AI and ML played in COVID-19? Because could you have models that maybe make things 10% better, but are you fighting against a political will that actually can't? It's like, well, it might be 10% better, but it's 90% harder to implement. Yeah.
Oh, the political no. The political side of this is fascinating for a variety of reasons, right? There are scientists that believe it's possible for one to be objective in the scientific endeavor, and I'm not one of those people. I think that we cannot separate ourselves from our past beliefs, from our politics. I think it's better to be open and honest about what they are, so that people can try and interpret where your biases may be. But from a infectious disease perspective, from a public health perspective, it matters how difficult it's going to be to implement something. And one of the things that's true almost universally in public health, and this is probably true in many sectors, is that it's better to do something early and decisively, even if it's not the best possible thing you can be doing, than to wait around trying to figure out what the best possible thing is. Now, certainly you don't want to do something that might be harmful to start with, but I think a great example of this is mask wearing, right? So there was a big push to not wear masks early. And a part of that, to be honest, was because of the supply chains and making sure that we had enough PPE for the healthcare professionals. Part of that was from influenza, where cloth face masks are probably not as effective as they are for something like COVID. However, the kind of cost of wearing a cloth face mask is pretty low. And so if we had just recommended that, we might have seen a really big benefit, even if the science was still a little bit uncertain then. Whereas obviously making a decision about going into a lockdown, that's a much harder, more expensive decision to make. And it's part of the reason that we delayed doing so, even though that ended up being quite costly as well.
Yeah, and it's strange that how countries that went into lockdown quicker than the UK and the US, for example, where they did that and garnered trust by being transparent about their decisions, they seem to have come through better. So I think the transparency is the other aspect of, if you're going to go early, if you're going to make a decision, make it earlier. But also transparency is a really important thing there. What's happening in the UK at the moment is, there's as our government ministers get pushback for their decisions. There's quotes in our paper today. People are saying, but we were following the advice of the scientists. That's what they told us to do. And yet the scientists have always gone with the quote that in the UK, the scientists advise and the politicians decide, right? So that from the advisors stick with that and go, well, we're just going to present the data. You have to make the decisions. And I think what you're saying is that maybe there's a little bit of overlap. That maybe are we simplifying that in the UK too much? And do you think there is overlap?
Well, I'd start by saying that there are probably a lot of people listening who are going to disagree with my position on this, which is okay. And to tie it back to your question that I didn't really answer earlier about the AI and ML, I think transparency is critical. It's one of the challenges with AI ML driven decision making is it's often hard to get transparency. And I think transparency builds trust, and trust is one of the key pieces for public health. I mean, for anything, right? And then I think honesty about how the decisions are being made, right? And so it may be that the scientists are trying to be as objective as possible, and that they really are advising, and the politicians are deciding. Well, then the politicians aren't following the science. They are taking in advice from scientists and using that as a part of a decision-making process. And that's related to AI ML, right? So one of the things that's important is that we include possible strategies that are likely to be politically palatable or something that can be implemented, right? So we want to consider vaccine rollouts that we can actually accomplish and that are simple enough that we can pull them off logistically, right? So you imagine saying in the US, instead of having these deeply complicated tranches of vaccine schedules, okay, we're going to go for over 65. We're going to do healthcare workers, something that's simple that we can get done. And that's very much related to the AI ML piece around all this, is that you can't separate the data from the objective functions from how the decisions are being made. And I think to say otherwise is really almost disingenuous in terms of how the process is really being done.
Yeah. So in a nutshell, do you think so much of the population might have assumed science was factual before COVID-19? I mean, I'm grossly simplifying here, but what COVID-19 has just shown over and over again is that a lot of science essentially boils down to probabilities, certainly in making this decision. It's like, here's the 5 things we think, and here's the 4 paths you can take and the probability of each outcome on which. And that's the best science can do. And then people disagree on those outcomes. So science isn't telling you a decision, it's telling you probabilities. Is that too simple?
Science is bigger. I know it doesn't seem that way right now to most of us, but science is bigger than COVID and public health. I mean, there are branches of science where it's arguable that objective truth is something that is obtainable, things in physics and those sorts of things. Mm-hmm. I think when we're talking about human social technical systems, I very much feel like we're in this realm where science should be about doing the best we can to qualify and quantify the biases, the way that we're evaluating the data, and the possible trajectories that we may be on. And one of the best ways to do that is with probabilities. And then we make those available in as transparent a way as possible, hopefully so that they can support decision making. But yes, I think to maybe just very briefly answer your question, I think that's exactly the realization that many people are coming to. And that's frankly, obviously also been one of the science communication challenges.
Yeah, absolutely. I think I think that is a really good place to stop this section, because in a moment, everybody watching, Sam and I are going to look at some of the latest vaccination visualizations to have a look at what people are doing for covering. But I am going to stop this section there, because I think you've just captured not only a great description for science, but for everybody in our audience who is using data to drive their businesses and their organizations forward. That's the reality of a reality of data amongst our audience. I think data's messy, it gives us some ideas, and we have to make decisions based on our best interpretation of that available data. So for this section, Sam, that was fantastic.
All right,
we're now going to take a little break and then come back and start looking at how the media is tracking vaccinations. Now we're going to look at some of the ways people are visualizing the progress of vaccination rollouts across countries of the world. So Sam's here. We're going to quickly critique some of these visits. I've got 4 to show. and compare. First of all, New York Times, we've got a map of the 50 states showing how vaccine rollout is going in your state, which is great if you're in the US. Timetoherd.com shows for any given country, how many days will it take on the current rate of vaccination for herd immunity to be achieved in that country? 329 days apparently in the UK. Vaccinology by David Bauer, which shows all the flags of the country and the saturation of the color. The saturation of the flag indicates the percentage to the entire population being vaccinated. So UAE is one of the leading countries at the moment. You can see it's a little bit more colorful than everyone else. And finally, Our World in Data, Oxford University-based project, showing has added vaccinations to its tracker. And here I've got UK, US, Sweden, Germany on the timeline. So, Sam, how are you seeing vaccination trackers, and what comments do you have on the ones I've chosen? Do you want to start on the New York Times? How do you like this one?
Sure. Yeah. So for me, the New York Times is a very interesting view because it shows what's been true for COVID from the beginning, that things are heterogeneous. Some countries have more COVID than others by a lot. Same with vaccination. Some states, same with vaccination. And then we zoom in. Like if I'm from Boston, I'm in Massachusetts, so I'll zoom in on Massachusetts and I can see the heterogeneity there. It's not on this map, but we can see county by county in Massachusetts, all the heterogeneity. Although the thing that pops for me on this is West Virginia, and they're the only state that opted out of a CVS Walgreens initiative related to certain long-term care centers in congregate settings. And that program's not been going well. And that's partly why West Virginia is doing so much better than other states, because they opted out of that program.
God, that's interesting, because I not being in the US, I'm not as close to some of these stories. My own reaction to this one was, I felt it didn't really answer any of the questions I had. It's like, okay, here's the overview. I can see which states are ahead and which states are behind, but I very immediately had secondary and tertiary questions, and the visualization itself doesn't give me the answers, and they have I have to go down to essentially a crosstab to find more details. So I felt like this one was just a little bit too brief for me.
No, I agree, and I mean, I know we're going to move on to the next one. I think maybe as a transition, there's a map that's coming out of Georgetown, just went live yesterday by Professor Shweta Bansal and her group, that shows coverage by race, ethnicity, and socioeconomic in the United States as a map. And I think that equity piece is critical. It's going to be even bigger internationally. And so just having a map where we're really seeing more about how this rollout's happening at the local level is going to be really important.
Yeah, and that's the clamor in the UK at the moment, is that the government is only releasing very, very high level national granular data, and it's like, well, great, but what's happening near me? All right, let's take a different approach. So this one from Deep AI, herd immunity. Now, we haven't got time to do the full description of herd immunity, but in a nutshell, in 15 seconds, Sam, can you describe what that is?
It's the fraction of the population that needs to be vaccinated, such that the risk of an epidemic there is low. Brilliant. And for COVID, that's probably about 70%. Again, this is an active area of scientific research. And one of the issues with herd immunity is that for some diseases, if it's 95%, that 5% of the population is much smaller than 30%. So you could still have big outbreaks with 70% herd immunity.
Yeah. So I think straight away, there's a challenge here in that it's showing a number 329 days about something that is inaccurate. There's many caveats here, which are all available. So let's see how you're doing in the US. So what's your take on this one?
Yeah, so I think this is a really creative idea. And for me, this communicates a critically important piece here, which is I don't want to wait 485 days to get to herd immunity. That's why we need contact tracing, case investigation, rapid diagnostic tests, et cetera, because the vaccine's not going to do it for us fast enough. But as you pointed out, I don't really care. I mean, I care about the US, and the UK and, Brazil and a bunch of other countries, but I want to know what's happening in my neighborhood. Like, when am I going to be able to safely go to the pub or sit down at a restaurant or teach in person. Northeastern's different because we have high rates of testing, but in places where you don't have that. And so the local level here is completely obscured. Again, that's a data problem, but I think is harder to conceptualize here what's happening in my neighborhood.
Yeah. I think you're right. The local is really important, but I agree. I found this one really fascinating because it frames the answer. It frames an answer to a question in a slightly different way. It's like, okay, how many people are receiving the vaccine? That's good, but we are all like, how long till we get back to normal? How long till I can be normal? And as we're seeing in France, it appears things are slow, and obviously each country is going to go quicker and slower at different phases. So I think all the caveats, they're all here. You can dig into exactly how they've done this model. They don't profess that it's 100% accurate, but it did really show the data in a different dimension that I thought was very compelling. And I believe the data all comes from the Our World in Data as well, which is a nice, reliable data source. Okay, let's go to another creative one. Had you seen this one before this recording, Sam?
I hadn't. I think this is super powerful and also very creative and captivating. So I think this is a great visualization and really shows both how slow we're going with the rollout internationally and also how unequal it is by country. So we know within a country, we're concerned about equity and we're not seeing it in many countries, but internationally, we're not seeing it either. And you can really see that play out here.
It does have a pretty powerful, you can sort by continent. The reason I highlighted this one is because I thought it was really creative. And then the data visualization, I know a lot about how to make visualizations work. And my criticism of this is that color saturation is a visual indicator that we don't do it very, very accurately. It's not that easy to see that the UAE is actually quite far ahead. And I also think that certain color flags don't show up very well. So, the Israel flag is really quite a dark blue. So even though they're kind of leading the world, the dark blue isn't very much different to completely monochrome. So I think, again, creative one, but one I might not judge decisions based on.
No, I think, I wish it was easier to see. I agree with you. The one thing I would really suggest they do if they're going to stick with the saturation is a way to sort by population size or sort by the impact of COVID, because I think that would really, really strikingly show the inequity.
Yeah, absolutely. And with all criticism, David Bowers, he's an expert in this. He had an intent to show this one way, so I'm not going to criticize his decision. I think it's probably garnered a lot of attention because of its novelty, and that's no bad thing. All right, and then the final one is Our World in Data itself, and they have the timeline trackers. They have recently added vaccinations to their data explorer. I'll just go first. I like this one very much because it just shows progress, and I think that's really important. It's like, are we moving forwards? It seems the UK is doing a good job currently. Whether we can stay on that path or not is to be seen. Let's hope we can. So it's the only one I found in these four that really showed progression over time in such a clear way. So any thoughts?
Yeah, that was actually going to. It was going to be my comment about the time to herd immunity, and they may be incorporating this under the hood, but we expect that it's going to take a little bit of effort to get ramped up, and nobody thought in the U.S. we were really going to vaccinate 20 million people in December. I think it's actually not so bad that we did 10 million, and so it is that trajectory that we care about. And in some ways, there's a really important analogy here with COVID, right? It's the trajectory for COVID that matters. It's the trajectory for vaccination that matters. A lot of the same things that make it difficult for COVID to spread through populations may also make it difficult to roll out the vaccines, rural areas, how people make decisions, human behavior. And so there's actually a lot more wrapped up in this that we've spent the last year kind of thinking about with COVID, that really kind of shines out as you can see the change. The UK shooting up, the US, slowing down almost, it seems, that this is going to be important to track as we go forward.
Yeah, I think you capture just one of the challenges anybody working with data, trying to communicate a data story has. It's like, how granular do you go? How much detail do you go? So here they went, we're just going to show the states, and they're not going to give me the local data, right? But that's their decision. That's fine. And then, in this one, they've kind of reduced it to a KPI, 1,640 days till herd immunity. Everybody now, everybody knows that that's not today. That herd immunity is not the signal that life goes back to normal. But when you reduce things to a KPI, that's great, but it doesn't really tell you what else to do. Similar with the vaccination flags, and yet here you've got a path. But even on this one, it's like, could you show more? Could there be more reference lines? Could there be more annotations? And that's the challenge we all have when communicating with data. Right.
Well, they all have different purposes too, right? I mean, it just
yes.
Very quickly end there, right? I mean, like the KPI, that's the kind of thing I can get a soundbite in if I'm trying to convince people on the radio or on TV that we have to bring in other measures. And then, the trajectory change helps tell the story about how things are speeding up or slowing down. And the country shows the equity, and then the international shows the equity, right? And so, I mean, that's just as I advise people about COVID data, and in the business world to have lots of different data streams, lots of different stories that you're telling. It's the same thing here, right? Like we have 4 different visualizations that are doing 4 different things. There may not be a way to integrate all of them into one perfect visualization, but that's why we have, it's important to have a breadth of ideas and expertise as we're telling stories with data.
That's really profound, Sam, I think, because I've never thought of it in this kind of way. I chose these because they showed things in different ways at different levels of granularity. But I think, you've just given me a great piece of advice there. It's like having each of the different levels of granularity as you try and convince people to drive change. I love it. So what a great place to stop. Sam, thank you so much for your time. Thanks for your comments on the vaccination and rollout. Thanks for going through these vizzes with me. Anybody watching, let us know what you think of these visualizations and which vaccination charts you've seen in the wild that you like or loathe. There are plenty of links down below to Sam and his work. And with that, Sam, thanks very much. Thank you to everybody who's been watching, and we will see you again soon on If Data Could Talk. Take care.
Thanks for having me, Andy.